Alright, so chronic pancreatitis, that is when there's inflammation of the pancreas, but it's progressive. It's a progressive disease, and remissions and exacerbations occur. Um, Alcoholism is typically the primary risk factor for chronic calcifying pancreatitis, also known as CCP, and that's the most common type of chronic pancreatitis. Now, chronic obstructive pancreatitis, that develops from inflammation and obstruction of the sphincter of Oddi, and it's typically from gallstones. Now, autoimmune pancreatitis, that occurs when there's some sort of underlying autoimmune disorder in which the immunoglobulins invade the pancreas. Now, other types of chronic pancreatitis predispose the patient to cancer, but there is not any evidence that autoimmune pancreatitis is a risk factor. Hereditary chronic pancreatitis is associated with gene mutations. Most patients with chronic pancreatitis have a decreased pancreatic secretion as well as bicarbonate. Now, these patients' stools are pale, bulky, and typically have an offensive or a foul odor, and that's from the colonic bacteria and the unabsorbed lipids. Now, the loss of pancreatic endocrine function is the reason why some patients with chronic pancreatic insufficiency develop diabetes mellitus. Now, key features of chronic pancreatitis, we're going to see jaundice, dark urine, steatorrhea, clay-colored stools, possible left upper quadrant mass if a pseudocyst or an abscess is present. We're going to see that intense abdominal pain that's burning and continuous. Now, non-surgical management for these patients, we see drug and nutrition therapy. Pancreatic enzyme replacement therapy is given to prevent malnutrition, malabsorption, and excessive weight loss. Now, it's important that these patients take their enzymes with meals and then with a full glass of water, okay? You want to make sure that the enzymes are given after antacids or histamine blockers because decreased pH levels inactivate the enzyme. The tablets and capsules should not be chewed. They should be swallowed, okay? You can put the gelatin in applesauce if the patient needs to because they can't swallow the pill. Now, a lot of times these patients are going to need 4,000 to 6,000 calories a day. Foods high in fat are avoided because of the increase in diarrhea. And also we want to have these patients avoid alcohol. Now, surgical management, typically it's not a primary intervention, but it can be done if the patient has ongoing abdominal pain or any type of abscess or pseudocyst. Now, prevention for exacerbation of chronic pancreatitis, that goes back to avoiding those foods that are high in fat, eating the bland diet, high protein, avoid any stimulants such as spices, alcohol, caffeine. We want to avoid those things that make those symptoms worse, okay? Avoiding smoking, that's going to help. Now, when we talk about pancreatic abscess, the clinical manifestation, typically we're going to see a high fever, but the manifestations are going to be similar to that of a pseudocyst. And when we talk about a pseudocyst, pseudo means false. These pseudocysts are encapsulated structures, and then they form either on or they surround the pancreas. Now, pseudocysts can spontaneously resolve, or they can rupture and produce hemorrhage. When we talk about pancreatic cancer is typically difficult to diagnose early. Clinical manifestations, they depend on the site of origin. Now, the head of the pancreas is the most common site. The body and tail of the pancreas, when their cancers invade the body and tail, they're typically very large, and these tumors can sometimes be palpable as an abdominal mass. Oftentimes, these tumors will spread and metastasize to the liver and cause hepatomegaly. The body and tail cancers, they spread more extensively than do the head of the pancreas cancers. Now, VTE is a common complication because of the blood's hypercoagulable state. Pancreatic cancer cause is unknown, but the most highest risk population are individuals in their 6th to 8th decades, and those with personal histories of smoking. Other risk factors are diabetes, chronic pancreatitis, cirrhosis, a high intake of red meat, obesity, older age, cigarette smoking, male gender, and family history. Now, when we are assessing these patients, the first sign might be jaundice, and jaundice is actually a late sign. So we know that pancreatic cancer is typically very insidious and slow and hidden. Okay, so with pancreatic cancer, we're going to see some key features in chart 59.5 on page 1227. We're going to see jaundice, clay-colored stools, abdominal pain, weight loss, anorexia, splenomegaly, glucose intolerance, weakness, and fatigue. We want to make sure we're observing that abdomen for any distension and swelling, which could be ascites. Percussing the acidic abdomen is going to elicit a dull sound, and that's typically seen in the advanced stages of the disease. Now, the patient will have an elevated carcinoembryonic antigen, or CEA level. Abdominal ultrasound and CT is enhanced with contrast are going to be performed for confirming the tumor and differentiating the tumor from a cyst. Chemotherapy or radiation are used to relieve the pain for the patient. Chemotherapy typically has limited success in increasing the survival time for these patients, so pain is more palliative. Now, we want to management is more palliative. We want to make sure that we're controlling these patients' pain. Biliary obstruction, if that's the problem, they can place biliary stents to help with patency to relieve pain. Surgical management, we can see partial pancreatectomy. That's preferred if the tumor is smaller than 3 centimeters. We can also see the Whipple procedure performed, and we talked about this a few chapters back. With the Whipple procedure, typically they remove the head of the pancreas, the duodenum, part of the jejunum, and part or all of the stomach and the gallbladder. Okay, if you'll look on page 1229, figure 59.3, that shows you the Whipple procedure where the anastomoses are. On table 59.5 on page 1229, that gives you potential complications of the Whipple procedure. Now, complications as far as diabetes, we want to make sure we're checking those blood glucose levels often. Hemorrhage can occur, wound infection, and bowel obstruction can occur. Now, fistula's development is a very common and serious complication. We have to worry about peritonitis as well, okay, with those fistula developments. Now, we want to detect any early signs of hypovolemia, and we want to prevent shock. For these patients, immediately after the Whipple procedure, that patient may become hyper or hypoglycemic because of direct manipulation of the pancreas and because of stress. So most of the endocrine cells are located in the body and the tail of the pancreas, and they're responsible for this hyper or hypoglycemic state. Now, glucose levels, we want to monitor those frequently during the early post-operative period. And if the patient is experiencing hyperglycemia, we want to administer insulin injections as prescribed by the MD. We want to make sure that the family members are being taken care of as well. because remember that pancreatic cancer, most of the time the interventions are palliative, and we're trying to help the pain and manage the symptoms. These patients typically, they have a diagnosis of pancreatic cancer just a few months before death occurs. So we have to take into account the patient's emotional state as well as their family members' physical and emotional health being at risk during that time. So I will begin in the next audio with chapter 60.